Good evening, everybody. Thank you so much for coming to attend the annual Beveridge lecture. It's wonderful to see so many of you here today. I should have put my slides up before. I just want to start by acknowledging the traditional custodians on the land on which we are today. So here on the Camperdown campus at University of Sydney, we are on the land of the Gadi people. And of course, these lands, we're going to be talking about first Ian Beveridge, who's heralded as starting the concept of one medicine. But of course, our Indigenous ancestors on these lands engaged in a One Health framework in everything they did, their connection to country, their connection to each other and ancestors, and to their connection to animals through, every person in Indigenous culture, even today, has a totem animal who best represents. So really, we're building here on that long history, generation and generation of learnings. And here on the university, we're marking our 175th anniversary of the university, but that of course pales in comparison to the knowledge exchanged over 60,000 years with our Indigenous ancestors here. So my name is Jacqueline Norris. I'm the Head of School and Dean of the Sydney School of Veterinary Science. And I'm really pleasured to introduce the concept around the Ian Beveridge Memorial Lecture. Having acknowledged country, and just as a side, we have an amazing Indigenous artist who's painted for our school some incredible artwork that is going up, and this is an ongoing connection that the Faculty of Science in particular has with Indigenous leaders. So our campuses go, of course, we're here in Sydney, and we're here on a Gadigal land, but our Camden campuses sit over the Nepean River, which is on Dharawal land. So we really have across multiple countries. So why Ian Beveridge? So he was a graduate of this university in 1931, and he had a very broad, interesting career that spanned investigating sheath rot in sheep, foot rot in sheep. He also made huge advances in influenza viruses, which of course is one of the topics of our guest speaker today. He introduced the international nomenclature and classification around cancers in domestic animals. He went then overseas and he established the Cambridge Veterinary School, which of course is still existing today. And for 18 years, he chaired the World Veterinary Association. He came up with this term, one medicine, which at the time was very novel, the concept that we would think about veterinary medicine and human medicine in the same sphere. But of course, as we know, those things have expanded enormously since then to One Health, to planetary health, to One Welfare. There's lots of different terms. But all encompassing this animal, human and environmental connection. So it's my great pleasure to introduce our guest speaker for tonight, Dr Sarah Britton, who again is a graduate of this veterinary school at the University of Sydney in 1990. She's been an executive leader for about 30 years in the One Health and biosecurity sphere across government, private and also not-for-profit organisations. She's currently the Director of One Health at the interim Australian CDC, or Centre for Disease Control, and Principal Consultant of One Biosecurity Solutions, and a Non-Executive Director on several boards. She was previously New South Wales Chief Veterinary Officer, and I think at a particular time in New South Wales history where I think she got confronted with more outbreaks of disease and had to use her knowledge to contain and lead our state around those emergency responses and outbreaks. She's owned and operated 2 veterinary practices, both in the city and in regional areas, and of course is deeply committed to advancing One Health and strengthening connections between that animal health and ecosystem. So it's my great pleasure to ask Sarah to come to the stage to give us some insights from her perspective.
Thank you, Jackie, and thank you very much for coming this evening, and it's a great pleasure to be able to speak at this memorial lecture for Ian Beveridge, so absolute privilege. So I just wanted to highlight here that these opinions expressed in this presentation are solely mine and not necessarily representing the Interim Australian Centre for Disease Control. So tonight I'll bring a different perspective to this lecture. So I'm not a One Health researcher, but come from a background of One Health policy, One Health emergency management, and I'll draw upon some of my experiences as a former New South Wales Chief Veterinary Officer and how One Health has been operationalised and what that looks like and how we can actually bring research into policy and bring that together. So one thing, One Health Day, we commemorated it yesterday, so a fantastic time to be able to celebrate bringing things together and a very fitting time, and I'm sure that was intentional, Jackie, for this lecture to fall at this particular point in time. So I think the key part, and I'll just go back one, I think the key part with the One Health is where we've come to from all that time, from when Ian Beveridge coined that one medicine. And so as Jackie mentioned, one medicine was around health and human health and animals, and where we've moved to over a period of time. So in the 1960s, that was a popular concept, and then over a period of time, we have moved to the One Health concept. And really that came around early 2000s, the concept bringing in actually ecosystems and environment. And it was the advent of Ebola that brought this term into perspective, and then actually was in a paper about One Health in 2004. So I will put up the usual slide about One Health because I'm sure I'm really speaking to converts here that most people understand it, but there is so many definitions, and I think it's probably the biggest challenge of all is what is One Health, because it's such an unusual concept, but it's so holistic that it is often quite difficult to get your head around. So defining One Health, and I think this definition is one that within the CDC that we use commonly, and this coming from OLEP, which is the One Health Higher Level Expert Panel, have pulled together this definition. And I think really the important part in this is about the integrated unifying approach. It's the interconnectedness. We don't live in a world of silos. We don't live in a world that is just animals, humans, environment. It's an interconnected world. And I think the key part there is it recognises the health of the humans, domestic, and the animal, plants, and the wider environment, and that what we do in one area impacts and has a significant flow on to other areas. In the recent Lancet article that was published, it was described as a healthy social ecological system. And I think this is what we're trying to get, that it's bigger than just emerging diseases, it's bigger than just zoonoses, and it is about how we actually intersect in the systems, clean water, energy, food security. The 4 Cs, this is the common part. Now you often will see this picture as well, and really One Health is this mechanism. It's a way of working, it's a way of doing, and it brings in the 4 Cs, the collaboration, the communication, the coordination, and the capacity building. So what this is depicting is trying to bring in all those sectors and the community to get that holistic approach and taking a systems approach. That's what One Health is, and that's for us at the CDC is what we focus on integrating, is that action of the 4 Cs. I'm not teaching anything new to any of you in this room because I know that many of you are working already in this One Health space and working One Health research. But I think the key thing is about then how does that look when we need to operationalise it? How do we actually take that action? So I'm going to take you through a series of events that have happened over time, or real life stories, to bring together just how that works and how we could potentially look at how bringing researchers and policy makers together. Fancy that we could actually collaborate and coordinate, that we could inform policy with research, and we could also work with researchers to help us fill the gaps. In my former role as Chief Veterinary Officer, we had many, many events, which you'll hear about some of them here. But so many times we were faced in a situation where there was no guideposts. We didn't have all the knowledge, and we had to make decisions on what to do. It would be fantastic if we had that intersection with One Health research, because often we find that work's been done, but it's not been published, or we don't know it's there, and that could help inform decisions. So this photo, many of you will have seen it around on the internet. It's been around for a very long time, and it's usually accompanied by a statement that's probably not something I could repeat here. But often, you know, this conjures different ideas for everyone here, and I'm sure that you could ask any single person here and you'd have a different response to what this picture looks like. But I think it does very much represent what we've got in modern society today, the intersection, production animals, the intersections with humans. And for me, the one thing, I guess, we look at this and you go, what's this zoonoses, and is this ground zero for the next pandemic? What's going to happen here? And I think it reflects back, this actually was around the period back in 2009 when there was a swine flu epidemic, and that was when there was that triple reassortment of the bird, swine and human flu viruses, with a further combination of the Eurasian pig flu virus. So many would reflect back to that. And I think this is a really timely part, because being the Ian Beveridge Memorial Lecture, that influenza should be one of the topics that we actually discuss today. So I think we live in a very connected world, and One Health really needs to be there to be able to tackle some of the problems that we face now. We see it also often in the news. We see constantly evidence of how connected our worlds are. We have got increasing human populations. We have increased number of production animals. We have decrease in biodiversity, and only 4% of the animals on the earth now are wildlife and wild animals. We've got increased connectedness through international trade. We've got urbanisation. We are losing some of the biodiversity areas. All these factors lead to needing to find solutions that have a One Health approach. And that One Health approach is actually bringing in experts, bringing in different ways of thinking, bringing in people from different areas so that we can approach it and get out of our silos. We have a much better way of then tackling these complex problems. So even more so than ever, the impact, if we don't do this, is impact on food security, impacts on environment, impacts on human health. When we make a change in one area, we need to be considering across the board what the impacts for the health of the ecosystems, animals and humans are simultaneously. So talking about influenza, and I'm just going to touch upon this. Now, I'm not going to go into depth and detail, because they would be a lecture in their own right of each of these different events that I highlight. But I wanted to highlight this one first, because this is one that we're actually in the preparedness phase. And this is one where we have had all the warning we can get. It's everywhere else in the world, but not in Australia, not New Zealand, and a couple of little islands just nearby. So this is an opportunity for us. You'll see in everything else I present, we never had the opportunity. We're at the other end, we're responding, and we haven't had an opportunity to be able to bring a One Health approach to this. So as most of you are aware, you're not telling anything new, the H5N1 virus, it's been around it's been around for a long time, but there's a lot of media about it in recent times. It started in China in the 1990s. And gradually over time, it has adapted to wild birds and has spread around the world, often quite swiftly. As we saw it go through South America, it quickly went through South America in 6 months and has adapted to move around and into mammals and affect mammals, and even we know a whole variety of animals have been impacted. There's been spillover events to humans, and specifically we have seen a number of those in America from their dairy production, and certainly from people that have been in close contact with sick poultry. So we've got this really unique opportunity because we're watching this worldwide. We've seen it come down South America, we've seen it coming to Antarctica, and now we're watching it just gradually hop on the islands, gradually through the south. We have an opportunity to be able to do this because this is going to have an impact on our ecosystems, our wildlife, significant impacts on our wildlife. It's going to affect our production animals. And then always with influenza viruses, the risk for human spillover or reassortment and potentially becoming a human-to-human disease. So this disease, I think, is one of these unique opportunities where us working together and has been a really great example. So at the Australian government level, we have at the HPAI task force, which we have been working on a number of different fronts in preparedness, but I know within each state and within each organisation, and I see representatives here of some of the key organisations that are doing absolutely instrumental work and will be so important in when we, and I say when we because I can't see how we're going to avoid getting H5N1 here, that when we get that, it's going to be critical that all these experts work together on managing how we're going to get through this disease, because it's here to stay for when we come through it. So this is really a classic example. During my time as the chief vet, we've had avian influenza in Australia, which has been the H7 version. And if there is a silver lining, the one thing is that that wasn't a disease that had adapted well to wild birds. So it was a disease that we could manage and eliminate out of poultry, and we could actually declare our countries free. Unfortunately for H5N1, that's not going to be the case. And the more that it gets into animals and spreads, then the more likelihood we have changes. Has been concerns on the human health side that there has been more severe cases. So whilst we've seen in the US only mild cases, certainly in Cambodia, there has been a slight reassortment where we have seen some more severe cases in the humans. But again, has not, despite all these the time of spreading around the world, we haven't seen anything that's gone from human to human transmission. So this is one which is actually a perfect opportunity for us to work on in preparation, and there has been some great work that has been done to date. But despite that, I'm sure when it comes, we still probably won't have everything ready, and we cannot predict how it will come and what the impact will be. Now that's just got stuck. Just wants to stay on highly pathogenic avian influenza.
Oh, it's a good topic anyway. I'm all out of ideas. I might just taskmaster out of.
Yeah.
I have never had this happen in 20 years of lecturing. Oh, there you go, Sarah. Is that you? Which one are you?
Thank you. Thanks, Jackie. So we'll move on to a new topic. Salmonella enteritidis. So this was an outbreak in 2018. So at that time, it started with a meringue cake. So May 2018, we got contacted by New South Wales Health to outline there was a cluster of human cases. And the New South Wales isolates, by whole genomic sequencing, they're able to link them together in a cluster. And over a period of time, able to associate it with this meringue cake at a party that various people had eaten. So the key part, this was an absolute great example of a One Health approach. So what they had to do was to trace the eggs and to trace back, and it took months of time. But in September 2018, in my former role, I got the phone call to say, we have traced the eggs to a property in Western Sydney, and we believe this is the property that's potentially caused the contamination of this meringue cake. So at that time, the combination of animal biosecurity and the food went out to investigate and to take samples from that property. And what began then, this Salmonella enteritidis outbreak, we ended up with 18 properties, 17 egg layer and commercial and 1 grading facility, 9 in Victoria, which was associated with backyard and spent hens. And we could link all of these properties through movement of eggs, trucks, people. So this ended up going on for several years, where it just would sporadically pop up here and there. And we really couldn't work out why sometimes the connections happened. And what we found is that you could have a property that had Salmonella enteritidis in their poultry. Next door, you would assume that that property somehow got connected through rodents or movements, but we'd found that the egg industry at that point, there was a lot of topping up eggs, and so eggs would move all around the country. So we traced some eggs, and they would then move from Western Sydney down to Victoria, through a warehouse, through a couple of other properties back up, and then they'd be sold at the farm gate two properties down. So by then had managed to contaminate several properties down through Victoria and back up through their track. And trying to link this all together, we were able to link all the properties and all through basically human movement of eggs, trays, equipment. So the interesting thing with this Salmonella enteritidis was, as we were in the throes of the outbreak, was how are we going to manage? Like, was this going to become, were we going to become the UK, where Salmonella enteritidis meant eggs weren't safe anymore, and they ended up implementing the Lion system, where there was a system where you could accredit the eggs and you knew that it was safe eggs. Fortunately for us, and for what factors, this has just bumbled along. We thought we'd got rid of it, and then 6 months later, a property would, we would get a human. The humans were the sentinels, because for the poultry, they didn't show any signs. Most of them weren't sick. So the only thing we could keep going by was New South Wales Health telling us about each of the people that got impacted and the whole genomic sequencing, and then we could come back to the clusters. But this is a true One Health issue, because we were facing an issue where we may have had to radically change how eggs were handled and how they were kept at supermarkets, and potentially no one could have their runny poached egg any for longer, or anything at your breakfast or your brunches, because all eggs would have had to been cooked hard, and we would have had to been able to potentially look at having to refrigerate eggs in supermarkets, etc. So there was a lot of discussion and conversation about how do we manage this. Not only is there the biosecurity of the properties, how do we protect humans from getting sick from the Salmonella enteritidis? So through a combination of things, for control orders we put in place, absolute tighter controls of biosecurity, we undertook surveillance of all poultry farms in New South Wales that sold eggs, and we were able to pick up if there was Salmonella enteritidis before it actually even got into the system. Fortunately, and due to the great work at Sydney Uni, there is a vaccine that's being produced and hopefully may be able to be commercialised in some point in the future for poultry farms to consider being able to vaccinate for Salmonella enteritidis. We have those complications about how do we do surveillance when we've got vaccination, and then how do we actually able to manage this. But considering for those properties that have been impacted by this, it's been a huge economic blow, a huge mental health blow, and really devastating. We end up killing all the poultry on the property, but also really most of the people that had been impacted by this went out of business. So this disease ended up having a major impact, and we still do see it from time to time. And it was interesting how it presented in New South Wales was through all the egg movements. But what we saw in Victoria was it was spread by spent hens. And spent hens are the hens that are at the end of their life, of their laying period. And what there was a really great resale value, because people thought, well, you know, we can rehome those to people in backyards. And actually, Salmonella enteritidis was spread around Victoria through the sale of spent hens, which are more likely to have Salmonella. Ironically, the number of cases that we ended up having, which was, 300-400, which we expect was probably 8 times that, because people didn't present to a medical facility. But coincidentally, at the time, there was another Salmonella outbreak, which was specific to a particular property and location, but it never made the news, because enteritidis really, it was new to Australia, and the problem we had was that this actually got into the egg, whereas a lot of the other Salmonellas were on the external part of the eggs. This was a consideration that we would have to change things significantly from a policy point of view. And so this is a great example where research and what's been happening further in the work out at Camden is going to actually make a significant difference in the policy and management of this disease. For many of you, Japanese encephalitis, this is familiar, and I know again some great work being done at Sydney Uni looking into many aspects of Japanese encephalitis. But this comes back to, again, always Friday evening or eve of a public holiday, but this was Friday evening in February in 2022, and I got a phone call from the Australian Centre of Disease Preparedness to say one of the piggeries in New South Wales had Japanese encephalitis. And the leading question they said to me, had I spoken to the Chief Vet Officer in Queensland or Victoria? And I said, should I be talking to the Queensland or Victorian CVOs? And they said, well, we're not telling you anything, but yeah, it might be a good idea. So subsequently, obviously, we spoke, and to find that we simultaneously all had piggeries with Japanese encephalitis. So at the time when we had this was unheard of. We'd never had this in Australia. What was it doing down in the southern parts of the state? So there were so many questions at that time. And what did we have to do? And at that time, I was on the other side of the fence. I worked as a CVO in the animal industries. And for the first time ever, all the chief vets came together with all the chief medical officers to say, what are we going to do to manage this? And it's really interesting now because I work for health and been on the other side of it. But it was really difficult because we have a system on the animal side about how we're going to approach emergency animal diseases, and we have a deed that helps the animal industries so that we can activate a response quickly and have assurance that we'll be able to help fund the industries. And at that particular point in time, we had to say, for that to click into action, we needed to say we could eradicate this disease. And I remember being on that Saturday morning in that meeting, and we couldn't say we're going to be able to eradicate this disease. It's a mosquito-borne disease. Like, how's that going to be the case? But we were on with health, and health was determining that eradicating that disease would be eradicate the pigs. We can't eradicate the pigs, we can't kill the pigs. We're looking at a disease in the rear vision mirror, because by the time we saw the disease in the pigs, they had been infected weeks to months earlier. So it was a really interesting period where we had to actually all get on the same page, understand what the epidemiology of this disease was and what does that look like going forward. So interesting, in the 2022 outbreak, we had 45 human cases and we had 85 pig properties across New South Wales, Victoria, Queensland and South Australia. And we also had it detected in feral pigs in Northern Territory and Queensland. Fast forward, and again, we see it crop up again in the 24 or 25 season. And in that time, we had 4 jurisdictions affected, and we had 9 human cases, 5 deaths, and 31 positive detections in piggeries and mosquitoes as well. So I'm looking at Pat because he's here and he's our key man in pulling all the epidemiology of the Japanese encephalitis. But where we've moved to from way back then was, how could we have known this was coming? Like, surely it just didn't appear. We should have had some signals that this was coming. And that was the ability that if we could actually get the human health, the animal health and the mosquito data, and have been able to look at that across time, and which we did in retrospect, we could see how it moved down. We could see where it originated. We actually could see what happened. So the huge benefit in being able to bring that together resulted in an MOU between the government agencies to be able to contribute the data under this MOU to be able to analyse. So we currently have this MOU, we have the data on a platform that we can access, but as Pat knows and we know in the One Health unit, that's great, but you don't necessarily get timely data, and to be able to pull that data in, it's not necessarily cleansed, to pull that data into something meaningful is quite a challenge. And that's what we're trying to do ahead of the next season, because we're looking at it now going, JEV's here to stay. It might sporadically come to us in the south, but this is really an important way forward, that we actually can collect this data so we can map what to do, because it's important from a perspective of telling the animal industries, this is a risk, what can you do? It's also really important for us. How do we roll out the vaccination programs for humans, and where do we concentrate? There's not a huge amount of vaccine, so where do we focus these? But the interesting part of this is that we're still now, 25 going to 26, and the animal industry still have not been able to get the JEV vaccine through to be able to start vaccinating pigs. So they've had to rely on, previous exposure, autogenous vaccines. They haven't been able to intersect and perhaps mitigate the risk that pigs may pose just from that perspective of infecting mosquitoes. So this is a critical part where all of us working together, we have a human vaccine, but we need to be able to also mitigate this through humans and through the animals, and we also need to be able to bring together One Health groups about how we control this from an insecticide point of view and an environmental point of view as well. So again, another fantastic example of where we need to be working together, but even the challenges now that we have after the event and that we're trying to prepare for the next one, in just being able to pull that data together. I won't go into Hendra much, but I think it's just that absolutely, because we have got the absolute experts of Hendra and having done research into Hendra, but again, it's a really great example of One Health. And I think this is where the intersection of bringing research into policy is so important. So I can see Ali sitting in the crowd here, and Ali with her work with Rainer and Peggy and all the others, the critical part of this was that in the research done with Hendra is an ecologist was brought in. There was people that understood social behaviour, ecology, bringing in other elements into the research and into the policy helped uncover so many things that were questions for us when we were dealing with Hendra in both New South Wales and Queensland. One of the great things that I reflected on back in my time as New South Wales CBO was the opportunity where that research group would engage us on regular intervals and update us on their research. And that was so critical for our understanding for making policy decisions and about how we were going to go forward with the next Hendra case. It was absolutely critical, and I think it's something that I reflect that would be really useful as a way going forward is how we can actually get that research told, updated to policy owners or decision makers so that we can understand what we can do and utilise that in practice as we go. So the critical thing I think with Hendra is the understanding of getting right back to what's the real issue here, and so much of it focuses on what we're doing and changing the environment for the bats, especially in their main roost areas, the lack of the winter flowering. Like when that came forth, that was a really life-changing thing to understand that there was factors that we weren't just dealing constantly at the other end of trying to protect the human who insisted on putting their hand down the horse's throat in the dying throes, and then are actually concerned that they may get Hendra at that particular period of time. So this is a really, really great example of One Health, but I think it's a really great example about how the research can be incorporated into policy and into our responses on the run, and being able to understand what those critical factors are and what we could change to make a big difference across the board. Another one that we had was Ehrlichia canis, and this again during as Jackie said, I did have a fairly eventful 5 years as the chief vet role, but I think this one really highlights a number of socio-economic things. One Health is not always about zoonoses, and I think this disease more than any is about the social impacts, I think, in communities of how much change, and then the impacts on these animals themselves. This appeared up in WA in 2020 and proceeded to gradually move across the top end of Australia, and has periodically appeared in the southern areas, but mainly due to rehomed dogs that have come in from the northern area. It causes significant health issues for the dogs themselves. But I think the thing is that it had a reasonably high mortality rate, and for a lot of the communities in the remote part of Australia, dogs are part of their life and part of the cultural community, and they live and exist. And this had a significant impact on the social fabric of, First Nation communities, but also just the emotional well-being, the hunting, pest control, the public health risks from, carcasses and the carcass disposal, and just a significant trauma. And it continues to cause problems. Through the work of AMRIC and other organisations that work in remote communities, that when they do visit, they help with tick prevention and other ways of being able to manage this disease. But I think it's really just a really great reminder that there's a number of things that we can do to help in the One Health space, but we've got to consider that the impacts are broad. We've heard food security. This is the social fabric of how this impacts these communities' lives, and what we can do is work with them, and how do we manage, how do we actually get the communications in a language they understand, and how do we best support those animals that haven't got good access to veterinary care. And sort of just to round out the case studies and just a different lens, is quite a few things that we saw were aquatic diseases during that period of time. And some of them, really great names like POMS, AVG, white spot, QX, a whole range of things. But I think this highlights the changing environment we live in and the impacts that has. So for quite a few of these diseases, QX was a disease that was periodically happening in different estuaries in northern New South Wales. And then it's caused by a protozoa, and it appeared in, just north of Sydney a period of time, which was devastating for the Port Stephens community. And it really had a significant impact, because not only did it make the oysters unwell, but really as a result of warming temperatures, water quality, all those things that change in the environment that impacted the oysters. It's a complicated disease because it has a life cycle that requires several different hosts, and so you may have the presence of the protozoa but you don't necessarily have the disease. But this had a far-reaching impact and put a lot of the oyster industries out of business, but also had huge mental health impacts on oyster growers in the Port Stephens area. And to the point now, as a result, they've had to change the type of oysters that they grow in that area, some that are more resilient to not getting this disease, but are at risk of other diseases. And many of you will have heard about white spot. And that was another disease that we saw that happened initially in the Clarence River area of the northern New South Wales. And it initially started in a hatchery in one of the prawn farms on this particular estuary. And we did a whole heap of surveillance and no sign of white spot virus in the wild or anywhere else. And it was a bit of a mystery. Why did this appear in a hatchery in a random farm on the Clarence River? So we continued to do, and it was a complicated area because we had prawn farms and we had the wild prawn commercial fisheries at that point in time. And really neither saw eye to eye, and they definitely didn't see eye to eye with government at that particular point in time. So one of the risks was that we were suspicious for it to get in the hatchery that it has to have come from the wild, but we couldn't find any evidence of it in the wild. And probably a few years earlier, in 2016, white spot had been detected in the Logan River in Queensland, which they had undertaken many, many years of surveillance to try to prove that had been clear. And just at the point where they were about to say they were clear, they picked up white spot again and it all started. So we felt like we might be in the same loop and discovered we were, because in February 23, one of the prawn farms on that estuary went down with white spot and subsequently followed through all the prawn farms in that estuary. So there was a big demand for the commercial fishers that were doing the wild prawn fishing to say, just close down the prawn farms and let us go. We knew that this had to have come probably from the wild. We just needed to be able to prove it. So that's where all the song and dance happens too, because there was a huge impact on this estuary. But again, it comes back to what we're seeing in the changing environment, changing water temperatures. This virus has gradually and subsequently we have found has come down and affected most of the estuaries in northern New South Wales, and has impacted significantly the wild prawn and pretty much put out the prawn farm businesses. So this had a huge socio-economic impact for that region. It had a huge mental health impact for that region. And whilst we are now, there is still control orders in place in the northern part of New South Wales, and we still have states that won't do trade business with New South Wales. During that time, lots of things happened, and we had bushfires, floods, COVID, lots of other, we had varroa mite, yellow crazy ant, red imported fire ants moving in from Queensland. And we had abalone viral ganglioneuritis in abalone that were moving in from Victoria. So the key part, what I'm trying to get with this, is the connection of environment with our health, and especially even of the aquatic animals. Really, the representation when they get sick, it's often showing that the environment is sick. And we need to be really looking at what we need to be changed. Should we be farming in those areas now as we see change with the warming temperatures? Or is there things we can do, like we saw happen in Port Stephens, is can we actually, the research show, develop new strains of oysters that are resistant to the disease? So there's ways we can manage it. Is there ways we can do things in the environment that can help filter? What can we do to change these things? And a lot of these lead to either the socio-economic impacts or food security impacts, or just direct disease impacts. So what I wanted to really then lead into is what we've seen in these case studies. They're not separate crises. These are symptoms of a fragmented thinking in a connected world, which is why we need One Health. One Health helps us bring together that connections and bring the right people in the room to be able to try to find solutions about how we're going to manage it. So I wanted to dip into the CDC because that's the next step. Where I currently am Director of the One Health in the interim Australian CDC, but the CDC came about as a result of the COVID inquiry and the desire that they needed an independent body that could provide advice back to government and to jurisdictions and to others that was able to bring great public health advice with data and evidence to be able to advise ministers and others that we need to go forward. So the interim CDC came into being in 24. And we are still interim, and we have the passage of legislation going through government at the moment, and we hope to be a standalone entity next year if everything goes well with the legislation. So there has been, it's heightened the public health emergencies, and part of the critical part of forming the CDC was that we needed to embed a One Health approach. So I wanted to highlight that as the CDC becomes a standalone, it is a public health organisation with a One Health approach embedded. And I highlight that because many have thought that the CDC is a One Health organisation. And the way it has been built, it is a public health organisation. And the key part is we'll be bringing together, doing the 4 Cs, bringing together all the experts, partnering with key organisations, but definitely developing those modern surveillance and data analytic tools. I've popped up there the objectives, and this was the objectives when the interim CDC was designed and had got the support from the government of the time. And really the key part, this still exists as we move towards being standalone, is being that organisation that can provide transparency, that we can provide advice. We're going to be a little organisation as we carve out of Department of Health. I think there's going to be like 200 of us at the most. Pat's saying maybe not, maybe we're a little less, who knows? Okay, 200 to 300 then, so we've got a little bit of capacity there. But I think the key part is that there is a focus on data, there's a focus on surveillance, and definitely focus on One Health as an underpinning to the public health advice that we'll be able to provide. As an enduring public health capability, we'll advise on the public health risks, provide those insights, and very much key about trying to become that trusted advisor, and with the public messaging, being transparent. So that's then been able to put up what we recommend, rather than necessarily what you'll often see is the things from government that can't necessarily get out there. The point will be is to have this transparent and to be able to share that information more widely. As I mentioned, the legislation's going through Parliament at the moment, and it's established very clear, if any of you have had the opportunity to read the interim information about what's available, then it's out of, you can find it on the CDC sites and other places, but it's very much about being independent. So we are currently moving out of the Department of Health, and we'll be an independent organisation. It's going to have a Director General as its head person, and they'll be appointed in line with the legislation, and they'll be the dedicated leader of the CDC. They'll have an advisory council, and that's being there to establish and guide the CDC and provide independent expertise. And we have agreements that we have to have with states and territories and other partners, because having moved out from health, we need to bring those together. If you wanted to know more about the legislation, then please just scan that, and then you can get more information if you're required. And I can share this later if anyone doesn't capture it before I flick the screen. Got it here. And so just to cover a little bit about the One Health unit and what we're doing. So we're only a small team, we're only a team of 5. And really the key parts of what we do is bring that One Health approach, the 4 Cs, to what we're doing. So we're actually bringing the people together. We're not the experts in One Health. We're are connected, we bring the people, we collaborate, and we bring the experts together. And really important for whatever the incidents are, that we can actually underpin and bring a One Health approach across the CDC, but we're also looking wider across nationally of where we need to be going. And we're focusing on the preparedness and prevention phase. As I said, it's about these 4C principles. That's the key part about what we need to do to work, because that's what is going to reduce the impacts across the systems. If we take that, we'll consider much more a systems approach and bring in all the parts instead of fragments. So just to give you a little bit of an idea just of some of the strategic priorities that we've been focusing on, and these are big picture ones, because these are big gaps that we see from a One Health perspective that we need to get in place. And that focuses around One Health governance, because really there isn't any One Health governance in Australia. Like, everything's in the silos. What happens, we see it even now with the HPI task force, that something has to go through approval, up through environment, it goes up through approval through ag, it goes up for approval through the CDC, and then we all come together and then say, yes, everyone's approved it, and then we can move forward. We need to find mechanisms that actually, when we're faced with these events, that we can move forward much, much quicker. The other thing is One Health surveillance, and some of the people in the room here will be involved in that, is looking at how can we actually develop a proper One Health surveillance system, and what's possible, and how do we get the value proposition and the benefits to help us develop a good One Health surveillance system. The other key things is engagement, and we're fortunate to have Nick, who's in the front here with us, that comes from a social epi background, who understands behaviour and can assist us getting better understanding and how we embed a One Health approach across the CDC. And I don't know how many of you have been able to join us for our One Health Wonders series, One Health Symposium. We've held a number of events trying to bring together the key collaborators in this area. And the key pieces of work, as I've mentioned, are some of these things, working on some of the key areas like preparedness for avian influenza, but it's bringing the right people in the room. And I think that's one of the key things that we need to be able to understand. Who are those people, and try to get those connections. And the beauty of what we've been seeing today, because we've had the good fortune to meet with a few people at the vet school today, is trying to understand what is it that's happening in One Health research, and how can we actually bring that into something like the CDC? How can that help advise us, and how can we bring research into policy so that we can all benefit and see it in use? One of the other key projects, again, is One Health in First Nations communities, and again looking at the impacts, but how we do that from the perspective of the First Nations people, so that we don't have the repeated issues we do see in emergency responses, where their cultural needs, what they need and what's important in communication, is often overridden due to the event that's happening. So if we can bring this and get a better understanding up front, then we're better prepared about how we manage that, and especially when avian influenza potentially hits Australia. So one of the things I just wanted to finish with is just some of the challenges in One Health research. And I think I've highlighted, we need research to underpin the policy. So how do we connect the policymakers with research? And I did highlight before, one of the key things is where Ali used to come and tell us about the research, and we could bring that straight into policy. But there must be other ways, and it's part of the discussions today. How can we actually link those together and help inform what we need to be able to do, and especially at a national level? We're aware there's no One Health funding pot, and I'll say up front, the CDC is not going to be a funding organisation, but there is no, the different funding pots don't really fit. If you are trying to do One Health, it doesn't really fit, and it's often difficult to get that funding to fit that need. There's no central register of what's currently been researched. So it's often just word of mouth or connections that we find out that some fantastic work's happening in an area like JV or chatting to Michael today, just with the spillover work, all that stuff, like how do we find out that you're doing it? Because it might be that you're doing something that we're looking for an answer for. And it's how we reduce this siloed approach. So again, it's a One Health approach that we need to be able to take going forward, just even in the One Health research area. So the future direction, so where we go from here. And I think there's many places that we can consider what would be important. I'm keen to hear from this group about how do we combine research into the policy, how do we get that better One Health group, because it is tricky. It's why it's not done, why it's most people don't understand the concept or find it difficult. But I think this is no longer just a matter of medicine, and it's a matter of ecosystems, it's a matter of equity, it's a matter of ethics. And we've got robust models in epidemiology, ecology, economics, public health. What we need is the infrastructure and the institutional ways to be able to integrate them at scale. And I think, as I've highlighted, these case studies, they're not separate crises. It's about our fragmented thinking in this connected world. So if we take away 3 key messages from this, is that it is interconnected, we need to be able to work together, and it is multi-sectorial, and we need to bring diversity to whatever we're doing. We need to adopt a systems approach, and that's ensuring that we maintain a healthy biodiversity and healthy ecosystems. And we need to change how we prepare and bring back that One Health approach to preparedness. And hopefully we can actually minimise some of the impacts that we see from when we are actually in response. So thank you, and appreciate you taking the time to listen. Hopefully that we can find ways of even strengthening this, and part of our role in the CDC is trying to integrate and collaborate and bring people together. But we are only a small group, and it really does require the expertise and being able to make those connections with many of you that are in the room. So thank you.